Then next I will call Kruti Nusaran. Yeah, please come, no? Our presentation is on accuracy of RETINOMAX versus cycloplegic retinoscopy for measuring refractive errors in children.
Okay, very good evening. I will be presenting accuracy of RETINOMAX K plus versus cycloplegic retinoscopy for measuring refractive error in children. As we all know, refractive error is the most common cause of treatable blindness. And we also know that table-mounted autorefractors have been there and we are using them. But the problem in pediatric age group is that the lack of cooperation and lack of portability. Like if a child of age 1 or 2, or if you want to go on a screening in community, then tabletop autorefractors cannot be helpful. Also, cycloplegic retinoscopy requires an amount of skill that we cannot teach a ground level worker. So RETINOMAX is a handheld autorefractor that enables quick estimation of refractive errors, and it's useful for screening in children. So the aim of our study was to investigate its accuracy versus the cycloplegic retinoscopy, which we have considered at gold standard. We compared these results under both non-cycloplegic and cycloplegic conditions with RETINOMAX and then compared it with cycloplegic retinoscopy. So something about RETINOMAX, designed by the Nikon. It is a handheld autorefractor. It also gives keratometric values and it has a wide range from -18 to +18 of sphere and cylinder. It is just 1.08 kgs, very easily operable, and works on a retinoscopic principle. It has two modes, standard mode and rapid mode. So to reduce the accommodation, as used in other autorefractors also, we have fogging technique, but the quick mode, it disables that technique and gives us quick results. So we did it at 5-meter distance. This is the picture of the RETINOMAX. And at a distance of 5 centimeter used for the patient. And so we took children from age group from 2 to 12 years with clear lens, and we also took pseudophakic patients with clear visual access. We took 100 eyes, and in phakic eyes we divided into 3 age groups, 2 to 4, 5 to 8, 9 to 12. We estimated first non-cycloplegic, took sphere cylinder axis values. Then we induced cycloplegia and again did RETINOMAX, and then finally cycloplegic retinoscopy. Both time were noted. So the outcome was divided as in different age group and pseudophakic group. We used our basic pair t-test and standard deviation, and we also used bland Talman plots, which gives a correlation of two methods very nicely in a graphic form. So we had 70 phakic eyes, and mostly were between 5 to 8, 60%, and rest were 2 to 4 groups and 9 to 12. So this is the graph summary of the tabulated form of phakic eyes. And here, what I want everyone to see is the difference we had in non-cycloplegic and cycloplegic. This is the value of the RETINOMAX, and this is the sphere. So when used with cycloplegia, it was very well corresponding with retinoscopy, but in non-cycloplegic form, we were getting a lot of difference. But the cylinder and axis values were corroborating either used with cycloplegia or non-cycloplegia. Similar representation here. So these are the sphere values we tabulated in different age groups, and clearly in 2 to 4 and 5 to 8, the difference was clinically significant. Less than 0.505 is taken. So that 2 to 4 age and 5 to 8 non-cycloplegia cannot be used. But in 9 to 12, even non-cycloplegic RETINOMAX was giving a good value, and we can use it. So now another thing we used was a clinical significant difference. So sometimes the statistics, they don't correspond to what we see in clinics. So we saw the difference of we took 0.5 as the clinically significant difference, and we saw that in sphere, when used with non-cycloplegic RETINOMAX, 65% cases were clinically significant difference was there, which is a large difference, and which was reduced to only 17.5% when used with cycloplegia. All indicated the same things. These are the bland Talman plots. These are the two lines between which, if your points are lying, then there is a good agreement between two methods, and if these points are on the central line, that means the best correlation. So when comparing non-cycloplegic retinomax with retinoscopy, points were lying in between, but these points were lying on central line, which was showing a much better collaboration when used with cycloplegia. So our study showed that in phakic eyes, as we all already know, that with cycloplegia, if you're using this autorefractor, it will give good results. But in 9 to 12 children, you can use it without cycloplegia also. And next was pseudophakic group. Pseudophakic group, we see that all the values were within, it was collaborating well with or without cycloplegia. We all know it doesn't matter. But a difference came in axis values. A very large clinically significant difference was seen in axis values in pseudophakic eyes. And we could make out the difference was due to post-operative irregular astigmatism and low retinoscopic result that resulted in this kind of difference. So time taken was definitely more with cycloplegic retinoscopy and very less with RETINOMAX. To conclude, you can use your RETINOMAX in phakic eyes in older children without cycloplegia, and in pseudophakic eye, this is a very dependable method. Thank you so much.
Yeah. Now, finally, which you feel better? I mean, the cycloplegic refraction, or directly you can go with RETINOMAX? In what cases it is?
Yes, sir. So, after doing this, I can say that RETINOMAX is a very good device to use if you are using it with cycloplegia. After inducing cycloplegia, it is very well in phakic eyes.
Okay.
Pseudophakic eyes, we don't need cycloplegia. So, you can very well use. Pseudophakic children need repeated refractions.
Yeah.
So, it was very easy to do that with this device.
One more question is, any added advantage is there, especially in children below 5-6 years of age with RETINOMAX?
Sir, that was the point that they don't, the attention span of these children is very less.
That's why, can it be applicable in those age group? See,
Yes,
elderly
sir.
children, anyway, you can do it.
Yes, yes, sir. So in that younger age group, they don't let you do retinoscopy for a very long time. So that we need a device that can give a result in like 10-15 seconds.
Yeah,
So that RETINOMAX was able to do.
Okay, thank you so much.
Thank you, sir.
Nice presentation.
Yes, sir. Yes, sir. Sir, it is an handheld autorefractor. Can be used in adult children. It's just an autorefractor. Huh. Children, sir, yes. Children, but I'm sorry, sir. In Sir, in age group above 9 years, we found that it was giving good results. That's why we divided that kind of age group. I cannot be very sure that above or below it might be a margin. But above 9 year, non-cycloplegia, without cycloplegia, it was giving good results. But less than that, definitely overestimation of myopia was there, which was reduced after giving cycloplegia to the child.
Okay,
And
sir.
Only cylindrical power. That means astigmatism is very correct in the 9 to 12 years, about the 9 years age group. In previous studies, it shows that non-cycloplegic using RETINOMAX, it is very much equal to the cycloplegic retinoscopy
Yes.
in cases of astigmatism cases, but not with the spherical equivalent. And the spherical equivalent is somewhat more when we measure with that RETINOMAX.
in younger children, ma'am?
No, in older children.
In older
In
children?
older children also, you are telling that we can take it as
Yes, yes.
without cycloplegia.
Yes, ma'am.
But in previous studies, it shows that only for astigmatism they are considering.
Yes, ma'am, definitely. As normally we use autorefractors in children, like in even to 12 and 15 years, we prefer retinoscopy cycloplegic, considering they have some sort of accommodation. But my study, I would say that I had only like 15 to 29 to 12-year-old children. So for that, I got good results. But definitely a large number should be there.